Welcome everyone. This is Dr. Zapchinsky. In this presentation, we'll explore abdominal pain, one of the most common yet diagnostically challenging complaints in clinical practice. We'll walk through causes, diagnostic strategies, and a structured approach to evaluation. Abdominal pain is consistently among the top reasons patients seek care, whether from their primary care provider, the urgent care, or an emergency department. The challenge is that the causes can be broad, from mild, self-limited issues to emergencies that require immediate intervention. About half of patients who complain of abdominal pain do not receive an accurate diagnosis. What happens then? They come back to their PCP or they go to the ER, depending on their symptoms. We also need to remember that not all abdominal pain originates in the GI tract, another reason that abdominal pain is challenging. These are the top causes of abdominal pain that are seen either in primary care or internal medicine and in acute care settings or the emergency department. Notice that there is some overlap, such as gastritis and gallstones and diverticular disease, but also there are some non-GI related issues here, such as ectopic pregnancy and pelvic inflammatory disease. These are the abdominal issues that we absolutely cannot afford to miss. As you can see, not all here are GI related at all, and they are separated into three categories for you. There's the acute abdomen, caused from inflammation, such as appendicitis, diverticulitis, acute pancreatitis. Metabolic, from sickle cell or from diabetic ketoacidosis. Structural issues such as bowel obstruction, testicular torsion, a bowel perforation, all the way to high-risk vascular emergencies, which include mesenteric ischemia, more common in older people, abdominal aortic aneurysm, MI, and gynecologic causes. So that brings us to the anatomy and the physiology of the abdomen. A little bit of vocabulary. The abdominal cavity is also known as the parietal layer, and it holds the viscera, which are the organs, and the peritoneum. The peritoneum is a thin, continuous, single-cell serous membrane lining the abdominal cavity and covering all of the organs. Its job is to lubricate the organs and reduce friction between them as we move, as we breathe, as we have digestion. And important to know that the viscera, which are the organs, and the peritoneum, which is the lining, can become inflamed and cause problems. So the abdomen holds digestive, urinary and endocrine and lymphatic organs, and also shares the pelvic cavity with reproductive organs and the urinary bladder. Additionally, remember that the aorta, vena cava, and the branching vessels are also in the abdomen. The organs are protected by the peritoneal membrane, by the abdominal and back muscles, and the vertebral column. Pain in the abdomen can be directly related to the underlying organ or the peritoneum, or both. And sometimes the source of pain is hard to pinpoint, at least initially. To understand abdominal pain, let's take a brief look at embryonic development of the gut. The gut develops between 4 and 10 weeks gestation. And in the top picture here, you can see that the organs develop in kind of a simple tube that is divided into 3 regions, which are the foregut, the midgut, and the hindgut. Notice that they kind of develop in a straight line. Well, each of these little mini organs is tied to a neural pathway that connects to the spinal nerves. By 10 weeks, the gut actually rotates to the left or counterclockwise 270 degrees. That's almost complete circle. As these organs move into their new positions, the pain signals still follow the original nerve routes to the spinal nerves. That pain signaling does not get rewired when these organs move about. But the pathways are now different, or consider them as some of them are in detours, or they've been detoured. This is why some abdominal pain starts as diffuse and migrates. Some pain is referred, and then we have the different types of pains that we can look at. Types of pains include visceral, parietal or somatic, referred, and functional and migratory. The first two, visceral and parietal/somatic, are the basics. Understanding the difference between visceral and parietal/somatic pain helps us narrow the differential and recognize when a patient may be developing a surgical abdomen. Think of visceral pain or organ pain as a car dashboard warning light. It tells you something's wrong, but it doesn't exactly tell you where the problem is. Visceral pain comes from the organs, the stomach, the intestines, the gallbladder, the pancreas, the liver, etc. It is caused by stretching, distension, ischemia, or smooth muscle spasm. Think about hollow organs such as the stomach, intestines, and gallbladder that are typically filled with gas or fluid. Stretching or distending those organs causes pain. Think of them as being overfilled, or as in the case of a bowel obstruction, the gas or fluid cannot move forward, so it backs up and it stretches the intestine behind it. For solid organs such as the liver and spleen, that are surrounded by a protective capsule, the pain comes when that capsule is stretched or compressed, either because of tumors or, in the case of the liver, portal hypertension. Quality is how it feels to the patient. The patient will often describe this visceral pain as dull, crampy, achy, or pressure-like, or they just may not feel very well. It's hard for them to describe it clearly. Localization is very poor. Now, often the pain is felt midline, but not in a specific spot. A person would not be able to take their one finger and point. They probably would wave their hand over the area of the mid abdomen to a point where they think the pain is. Visceral pain is often associated with symptoms: nausea, vomiting, sweating, pallor, even fainting, dizziness, or palpitations, which can be debilitating. These are autonomic symptoms, and that's very much part of associated symptoms to visceral or organ pain. Patient behavior is often restless. They may shift positions to try to get comfortable. So early appendicitis starts as vague peri-umbilical visceral pain, and the person may have a lot of trouble getting comfortable. I remember a dialysis patient calling me one day between his treatments complaining of abdominal pain that was just kind of all over. And when I asked him about what he was doing, and he said, I can't do anything. I can't lay down. I can't stand up. I'm just uncomfortable. and I sent him to the ER. He had appendicitis. So let's contrast that with parietal or somatic pain. Now remember that parietal is the pain that parietal is the lining that surrounds the abdominal cavity and overlies the abdominal organs. It is also subject to inflammation at times. It is caused by inflammation, infection, or irritation. It feels like a sharp stabbing pain, and it's well localized. A person can point and say, it hurts right here. It will get worse when a person moves, whether they cough or you're pressing, so you get rebound tenderness here and guarding. Patient behavior, they're going to lie still because any movement increases the pain. So an example, as appendicitis progresses, starts out as organ pain, very diffuse little piece of intestine that's hanging out there. When it gets inflamed enough, it passes that inflammation on to the peritoneum. The peritoneum becomes inflamed, and then the pain moves to a very specific spot in the right lower quadrant and becomes parietal pain. So let's summarize the difference between visceral or organ pain and parietal/somatic pain, which is the peritoneal pain. The visceral pain is vague, deep, crampy, poorly localized. Okay, person cannot use one finger to show you where it is. Whereas parietal pain is sharp, localized, and it worsens with movement. A shift from visceral to parietal pain signals disease progression. So as in the patient with early appendicitis where they have diffuse or generalized abdominal pain, as that inflammation moves from that little finger of an appendix to the lining of the peritoneum, then we get a change in the symptoms. The parietal pain is more likely to indicate a surgical abdomen. We know when that pain localizes to the lower right abdomen, it's time to send them on to the surgeon. Parietal pain comes with guarding and rebound tenderness. Again, parietal pain is when the peritoneal lining becomes inflamed, and that's where, when you go to press on the abdomen, they're going to have rebound tenderness when you pull your hand away, or their muscles may tense with guarding as a protective mechanism. Other types of pain that you're going to see are referred pain, pain that originates in one spot, but it's felt in another. And that's again from that embryonic development that we talked about earlier, where the nerve pathways, they're the same, but they are detoured from where they were originally. So the best examples of radiating, or I should say referred pain, are gallbladder, which is to the right shoulder or the tip of the scapula, the pancreas, which is to the back. Danger signs for those types of issues that are not GI related, the MI, which is a left shoulder, is classic, not necessarily for women, but is certainly classic for men. You also have to consider lower lobe pneumonias in the absence of other abdominal symptoms. Migratory pain, this is the classic pain pattern secondary to appendicitis. What starts as a diffuse, generalized, dull pain early on, or visceral pain, organ pain from that tiny little worm of an appendix, changes to parietal pain over about 12 to 24 hours as the lining of the abdomen, the peritoneum, becomes inflamed. It settles at a place called McBurney's Point, which is halfway between the umbilicus and the anterior superior iliac crest. Another type of pain that you'll encounter in the clinical setting is functional abdominal pain. This is also known as gut-brain axis dysfunction. The gut-brain axis is a two-way street of communication between the enteric nervous system, or the gut, and the central nervous system, or the brain. They use the vagus nerve, endocrine and immune pathways to allow the brain to impact gut function. On the flip side, the gut microbiota sends chemical signals influencing emotional regulation and mental health. So the enteric nervous system is known as the second brain, and it lives in the gut walls. This isn't a made-up thing or voodoo medicine. This is real. Gut microbes affect the brain by producing neurotransmitters such as serotonin and dopamine. Common dysfunctions and disorders, or what we refer to as dysbiosis, is associated with disorders such as irritable bowel syndrome, Crohn's disease, functional constipation and diarrhea, anxiety, depression, Alzheimer's disease, Parkinson's disease, obesity, and chronic fatigue. I put this in here again because you're going to see it, and because the way that it's diagnosed is very different from an acute abdomen. This is chronic and recurrent without any identifiable physical causes or structural disease. It's often triggered by stress, previous infections, or anxiety. This is chronic or recurrent stomach pain that persists for at least 2 months and occurs at least 4 times per month without clear underlying physical or structural cause. Very common in children. It is real, and it often stems from visceral or organ hypersensitivity and altered brain-gut connection, where normal digestion is interpreted as pain. They're sensitive. The symptoms or the pain occurs around the belly button, and it may occur with nausea or headache or dizziness. It may be triggered by stressful events or anxiety, and there is no evidence of organic disease such as inflammatory bowel disorder or active infection. The management of this is identifying the triggers and managing the stress. This is not related to IBS because it is not associated with BM changes, and there are no alarm signs. So now that you've got all that behind you, what do we do for the patient that comes in complaining of abdominal pain? Well, these are the steps of assessment for nurse practitioners. We start with the chief complaint, and we move to the history of the present illness and all the way to the focused physical exam at the end. But I want you to notice that just above the focused physical exam is initial differentials and diagnostics. Assessing the patient with abdominal pain begins with the chief complaint. That is, why the person came in, and moreover, why did they come in now? We have to start thinking about differentials, or what could the problem be, as soon as we hear the chief complaint. That's going to guide us in asking the rest of the questions. The next thing is to get a history of the present illness, and there are a number of mnemonics that you can use. Old Carts happens to be handy. Onset. This refers to whether the onset of the pain was gradual over hours, weeks, days, months, that type of thing, or was it gradual? So keep in mind that chronic pain is pain that is longer than about 3 weeks, or it's recurrent. Think about the definition of the functional abdominal pain we talked about. We ask about the location, and one of the best ways is to ask the patient to point with one finger to the spot. If they can do that, you know you're dealing with something other than organ pain. So visceral or organ pain is diffuse, and the parietal pain is pinpointable. Duration and frequency. Okay, how long does this pain last when it comes? Is it constant? In other words, you can't do anything without there being pain. You're always in pain. Is it intermittent? Does it come and go? Okay, describe the pain. Is it burning? Is it gnawing? Is it crampy? Is it achy? And notice the difference here. You're going to start putting things together. With visceral pain, you expect it to be diffuse, and you expect it to be crampy, achy, etc. If it is somatic pain or parietal pain, you're going to generally that pain is going to come on pretty quickly. It's going to be well localized with one finger pointing to it, and they're going to describe it as sharp and persistent pain. Look at the aggravating and the alleviating factors. What makes it better? Can they lie down and that makes it go away? Do they have to move to make it go away? Does eating make it better? Is it better on an empty stomach? So eating an empty stomach, those are going to point more towards things like ulcers, gastric and duodenal ulcers. Are there any accompanying symptoms? Now here are your autonomic symptoms and your constitutional symptoms. Fever is a constitutional symptom. Nausea, vomiting, diarrhea, body aches, palpitations, fainting. Can you pick out the autonomic symptoms that are in there? What does this pain do? Does it sit in one spot or does it travel? Okay. If it travels, show me where it travels. Timing. Has the patient noticed that this pain occurs at the same time every day? After they've eaten? When they're lying down? Again, does it occur monthly? So be curious and get a good history. That's going to give you a lot of information. As you ask each of these questions, you are beginning to rule out things, or you will eventually begin to associate symptoms with different pathologies. And of course, ask them what their pain is rated on a scale of 0 to 10. Once you've gotten through the history of the present illness and you have some ideas about what may be going on, or a brief list of differentials, then let's get into the past medical history. This is documented history with diagnoses and dates. It's rather than a history of, it is a diagnosis of, such as hypertension, 2016, type 2 diabetes, 2020, inflammatory bowel disease, do they have Crohn's or ulcerative colitis? Ask about celiac disease or any kind of diseases where they have difficulty digesting foods. Ask about reflux disease. Ask about sickle cell anemia or any autoimmune diseases. Move on to the surgical and be very specific about your abdominal surgeries. People that come to you in pain are not often going to be reliable historians, and you may have to ask them. For women, do you have all your lady parts? Do you still have your uterus? Do you still have your ovaries? All right. For everyone, do you still have your appendix? Do you still have your gallbladder? and start there. Then you can ask them, once their brains are kind of prepped, have you ever had any kind of bowel surgery? Have you had hemorrhoidectomy? Have you had anything in your weight loss surgery? That's a big one. Have you had any kind of a gastric sleeve or Wine-Roux? Once you have that, you are narrowing down your differential or your list of possibilities. And let's move on to the social history and be specific here. Ask them about alcohol by asking, how much and what kind of alcohol do you drink? Rather than do you drink? Let's assume that most people drink, whether that they do or they don't. Then they can deny it if they don't. Do you use cannabis? Do you smoke it? Do you eat gummies? The reason about cannabis is that it is linked to things like cyclic vomiting, so you want to be aware of the cannabis use. Ask about sexual history. Very important, especially with women of childbearing age. When you are trying to rule out things like pelvic inflammatory disease and ectopic pregnancy, find out, are they sexually active? Do they have one or more partners? Do they have protected or unprotected intercourse? And for every woman of childbearing age, and that is children who have menstruated, through women who are in their perimenopausal stage, they are pregnant until proven otherwise with a urine pregnancy test or with a serum HCG. Move on to the family history and be very specific about GI cancers and GI diseases, okay? Especially any kind of syndromes that include the breast and the colon and the ovaries, any kind of GI cancers and GI diseases such as Crohn's and ulcerative colitis that may have and celiac that may have a familial or hereditary side. Then we move into the review of systems, and this is something that gets nurse practitioners constantly. This is a review of symptoms for the rest of the systems. This is the last part of the history that you address, and these are the things that you may not have gotten in the HPI that may help you reach a diagnosis. It doesn't mean that we have to ask 12 questions about every system. We want to make sure that we start with the constitutional symptoms, and those include any fever, chills, fatigue. Has there been any intentional or unintentional weight loss? Okay. Are there changes in appetite? Right. Have there been any changes in bowel or bladder that you did not ask in the HPI? Is there are there any palpitations happening? Any shortness of breath if you didn't ask this in the HPI? You'll learn what to ask. Again, we're talking about being focused here. Once you get through the history, you are beginning to make a list of differentials, and this will guide your physical exam. It will also guide any diagnostics that you want to make. Differentials are a list of potential causes that could explain the person's symptoms. Now, this is a skill. Becoming proficient in developing differentials is a learned skill. Med students and PA students, they've not been nurses before for the most part. They are taught this skill very early in their training, and by doing this, what they are doing is they are associating symptoms with disease processes. This is not something we learn to do in nursing school. What we learned to do was to make a list of nursing diagnoses. We were taught not to diagnose. We focused on the human response. But medical diagnoses are based on pathophysiology and linking symptoms to diseases, and we can learn how to do this. And we will practice this and get better at it or proficient over time. The differential is important for abdominal pain because the healthcare provider has to determine very quickly whether this is an urgent or a non-urgent, meaning surgical versus non-surgical issue. Is this an acute or a chronic problem? Keep in mind that chronic abdominal pain is rarely serious. You also are going to look at the risk factors based on age and sex. Can this be an ectopic pregnancy? Could this be pelvic inflammatory disease? Are there risk factors for MI? Is there a risk factor for abdominal aortic aneurysm? And these are the key steps. You gather your data from a comprehensive, focused H&P. Comprehensive does not mean head to toe. Those days are over unless you're doing a wellness exam. Prioritizing potential causes. What is the most likely versus the most urgent? There are mnemonics that can help you, such as vindicate, vascular, infection, neoplastic, degenerative, idiopathic, intoxication, congenital, autoimmune, allergic, traumatic, endocrine, environmental. We don't learn these overnight. Narrowing your options. You may need more history. The physical exam will help. Diagnostics will help as well. Critical thinking and clinical reasoning. This is how you come up with your diagnoses. And when you need to, you collaborate. That means you phone a friend. You talk to a colleague. If you're in the hospital, you talk to another provider. If you're out in the clinic, many times I've picked up my phone and I have texted a colleague when I needed help with something. And what I know is that nursing is a team sport, and it's very helpful to have connections. There's a method to the physical exam, and I want you to think about this: inspecting a palpable problem. So, inspection, auscultation, palpation, and percussion. You're going to chart those in the same order. Begin with a general inspection as soon as you lay your eyes on the patient. Does this patient look ill, uncomfortable, or in pain? What are they doing? Can they not sit still? Will they not move at all? That can be a major clue for you. Look then at the shape of the abdomen. You're going to look at the skin over the abdomen. You're going to look at for distension and for movement. Shape. Now I will tell you that obese abdomens are difficult to inspect other than looking at the overall shape and the skin. If the abdomen is distended, here's a little pearl for you. A distended abdomen, think of the 5 F's: flatus, fetus, feces, fluid, fat. Okay? Is there movement? Visible peristalsis. Probably only be able to see this in children and thinner adults if there's some sort of an intestinal problem. Look at the skin. Is there a rash? Many a shingles outbreak was misdiagnosed as kidney stones. Oftentimes the pain comes before the rash, and a person will end up in the ER or in your office saying, I hurt. Let that be part of your differential. Then you're going to auscultate. You don't want to stir up any gas in the bowel by pressing on it before you listen. You're going to listen for the presence or absence of bowel sounds. When indicated, you can listen for abdominal bruits, like the aorta, over the aorta or over the renals. Percussion. This is a forgotten technique, but it works very well for detecting gas and stool. So hone your technique a little bit. Palpation. Palpation is going to uncover tenderness, guarding, rebound tenderness, and you can use it to determine a fluid wave for ascites. As part of your physical exam, you're going to decide whether you need to include a rectal exam or a genital and pelvic evaluation as indicated by symptoms and by the person. Now there are some special maneuvers for assessing abdominal pain. So with your initial list of differentials, you may need to use some of these. Positive results are going to support your differential. When appendicitis is on your differential, you're going to check for rebound tenderness. Remember that when rebound tenderness occurs, it means that the peritoneum is involved. The lining of the abdomen is inflamed. With children, you can actually perform what's called the Markle test. You just get them to jump up and down, and if they have peritonitis, they will not. Okay. You can also pop them on the heel, and that can also cause peritoneal irritation, and it will cause pain if they have a peritonitis. Be aware that rebound tenderness can also occur in diverticulitis, but it's typically going to be in the lower left quadrant than in the right lower quadrant. Here's some graphics for you. McBurney's sign is tenderness at McBurney's point. Now McBurney's point is located between the umbilicus and the anterior superior iliac spine in the right lower quadrant. Pain there can be a sign of appendicitis. Guarding is muscle tensing over the abdomen. This is protective. It's usually not intentional. The body takes over. When you go to palpate, you'll notice that the muscles are tense. A sign of a ruptured appendix or severe peritonitis is when the abdomen is bored stiff. So rebound tenderness occurs when you push your fingertips down into the right or left lower quadrant and release quickly. The pain comes when you release, and that can be indicative of peritonitis. There's a sign called the Markle test or the heel jar test, and this is pain in the right lower quadrant after dropping onto the heels. There's not a picture of it here, but one of the best ways to describe this is watching little children jump up and down. They have a negative Markle test. If they had appendicitis, they would not be jumping up and down. It hurts. Another way to do this is to bend the knee and pop the heel. And if the peritoneal area is inflamed, you'll get pain. Then there are these three signs here that are also very helpful for you to learn. The first one is the obturator sign. All right, this sign is elicited by bending up the right knee, okay, and then rotating it internally. So when you rotate internally, it means that you are pulling the heel towards the inner part of the body. The knee is towards you. And if there's pain elicited in the right lower quadrant, that's a positive sign. The psoas sign is elicited when the right leg is extended, okay, and you ask the person to resist against you as you're bringing that leg up, and pain in the right lower quadrant is a positive psoas sign. Then there's Rovsig sign, and Rovsig sign is pain in the right lower quadrant that occurs when you're palpating in the left lower quadrant. All of these are signs that there is peritoneal inflammation. And the last of the signs that I'll share with you here is Murphy's sign. This is a sign that can be used for detecting gallbladder problems. I want you to think that if you've ever had an ultrasound, an abdominal ultrasound, especially in the gallbladder area, that the ultrasound tech is pressing pretty firmly up and underneath that right costal margin. So they're applying pressure to that area. If a person has gallstones or cholecystitis, an inflamed gallbladder, they may elicit a positive Murphy's sign, which means that when the hand or the probe is pushed down, then the person suddenly takes in a breath and stops breathing because it hurts. And that is considered a positive Murphy's sign. You can do this, you can elicit this by pushing firmly up in the right epigastric area, pushing up and into the liver area. If the gallbladder is inflamed, you'll get that positive Murphy's, which once again is holding their breath or stop breathing in mid-breath. This is a helpful picture of differential diagnoses for pain by the abdominal area. Not all abdominal pain is from GI sources, so there can be referred pain to the abdomen from pneumonias of the lower lobes, testicular torsion, ovarian torsion, ectopic pregnancy, pelvic inflammatory disease, urinary tract infections, kidney stones, MI, mesenteric ischemia, and aortic aneurysm. This is the importance of knowing the anatomy, being able to see which organs are in the area of where there's pain, knowing what's under your hand. Diagnostics are chosen based on your differentials and on your physical examination. Labs include CBC with a differential to look for infection and anemia, complete metabolic panel, liver function tests, urinalysis, urine pregnancy test. Probably if you're in the ER, you can order a lipase if you suspect pancreatitis, or a lactate for bowel ischemia, and troponins for an MI. Also, you can do an EKG if you're thinking that the heart may be involved. An acute abdomen requires imaging, and CT scans are the standard for acute pain from appendicitis, kidney stones, colitis, diverticulitis, tumors, vascular conditions, and trauma. The CT scan will reveal highly detailed cross-sectional views of all organs and vascular structures and bones. The pros here is that it's fast and accurate, and the cons are the radiation exposure, many times higher than a standard X-ray depending on the body part. Some organs absorb more radiation than others. I will say this, you want to be very careful about radiating or irradiating a fetus. So that is why you must have a pregnancy test before you go taking x-rays of abdomens in women of childbearing age. Ultrasound is the best or the gold standard for a gallbladder to identify gallstones, and for pelvic pain or gynecological issues. That reveals in real time images of the soft tissues, any fluid collections, and the blood flow. The pros, no radiation, very portable. The cons, limited by body habitus. So if a person is obese, it's often difficult to get a good contact between the skin and the underlying organ. Bowel gas also will disturb the image. An MRI is best for detailed imaging of the pancreas, liver, biliary system, or when avoiding radiation is necessary, such as in pregnancy and children. The MRI will reveal excellent soft tissue contrast and detailed evaluation of soft tissues and organs. The pros, no radiation, high detail, and the cons, it takes longer and is usually less available. Plain films or x-rays are best for quick initial assessment for constipation, ingested objects that are radiopaque, bowel obstruction showing dilated loops, or perforation showing free air under the diaphragm. So an x-ray can reveal a general overview of the abdomen. You can also do a chest x-ray, and some pneumonia pain can radiate to the upper abdomen. The pros for an x-ray, there's limited use, but low radiation, that's an important consideration. Typically now a plain film has very low radiation. The cons, can miss subtle or complex pathologies. These treatment principles are going to guide you well through all of your abdominal issues in clinic or in the hospital setting. You're going to treat the specific cause. If you don't have a specific diagnosis, empiric therapy can be used. Now, empiric therapy, this is therapy that is outlined in the guidelines for treating specific things like a gastroenteritis or constipation, diarrhea, nausea, vomiting. Okay, when you are unclear of what the cause is, there may be something in the guidelines that you can do without a specific diagnosis, and that is what we call empiric. That means historically, traditionally, this has been used to treat these symptoms when no diagnosis is clear. Your patients will need frequent reassessment when their abdominal pain is involved. Now, what does that mean? It means that if they are patients in your clinic, that you reach out to them and you have interaction with them, you bring them back sooner rather than later. If you're in the hospital with patients in the ER, then you're going to check on them frequently to see. When to refer? Well, let's talk about what I mean by referral. In the hospital, as a hospital nurse, you may see refer, and that means call and make the person an appointment. That changes when you become a provider. As a primary care provider, it means you can send them now, you can send them to the ER, you can send them to the surgeon's office, you can send them now. Refer to the ER doesn't mean wait 24 hours, it means send them to the ER now. This is all about using words and what they mean in different roles. So in the acute care, referral can mean let's call the rapid response, or let me call a colleague, or let me call a surgeon or someone to come. So you're going to refer when the pain is severe. If you're in a clinic setting and they come in with severe pain, stop. Just send them right away. I mean, you can take their vital signs while you're calling the ambulance, okay? But let's get them out of here. If they have a rigid abdomen, again, if you're in a private office, you're calling the ambulance. If you're in the hospital, you are getting the surgeon there right away. If they have worsening symptoms, that means they've been feeling lousy all day. They come into you and their blood pressure is really low. They're tachycardic. They're probably dehydrated. You're going to send that person on, okay? If they have a fever, especially a fever over 101, you're going to send them out. If they've got a change in their level of consciousness, you're sending them out of your office. You are not taking care of those patients in your office. If you're in the hospital, you are pulling your team together so that you can send them to the next right place so they can get the help that they need. In summary, abdominal pain is common and it's complex. The history and the exam are essential. Your differentials are going to guide you to what to do next, whether that's more history, a different type of an evaluation, diagnostic tool, labs, etc. The characteristics of the pain are going to provide clues: onset, location, characteristics, associated symptoms, your HPI old carts. Knowing your underlying anatomy. If you don't know it now, learn it as you go. This is a great time to learn it. Always consider life-threatening causes in your differentials, even when you're in a clinic setting. One caveat I'll say is that people that have chronic pain over months rarely have something that is acute and is going to be dangerous to them. That's not always true, but it is something that you can start with. Labs and imaging are going to refine your differentials. This day and age, we practice defensive medicine. Everybody gets a CT scan if they go in the ER, okay? But when you're in the outpatient setting, you're not going to do that first. That's going to be down your list of things. You're going to do your history, physical, any labs. You can send them for imaging, and you're going to make a decision as to whether or not you can take care of that patient or have to send them out. Deterioration of your patient always overrides diagnostic uncertainty. If they are deteriorating before your eyes, and this can happen when you're in a rural area and people, they're away from the clinic setting and they don't come in right away. They think they can get over it. This is when you want to send them out.